Hi, my name is Emma Kelling. It is 11/21/2021, and I will be doing my Unit 2 assignment case study. The first case that I selected to do was case study number 2 with a 16-year-old female with a deficiency of glycogen phosphorylase. The diagnosis that I came up with that corresponds with this is McArdle disease, which is a metabolic disorder. It's a deficiency or complete absence of glycogen phosphorylase. Some of these symptoms that correspond with McArdle disease are cramps, muscle pain, and weakness, and these correspond with beginning exercise. Patients with McArdle disease may tolerate light to moderate exercise, such as walking on level ground, but any sort of strenuous exercise can bring on symptoms quickly. So for this case study, we were asked to respond to some of the potential patients' questions, the first being a better explanation about how muscle glycogen is normally used during exercise. My response to this question would be that muscle glycogen is oxidized as a fuel for exercising muscle and is predominantly oxidized to lactate. Muscle glycogenolysis is activated by epinephrine and AMP, and calcium are elevated when exercising the skeletal muscle. The second question that the patient had was that she really likes to take long walks and is wondering whether she'll still be able to do this with her friends. My response is that yes, this is possible, being diagnosed with McArdle disease, but as I previously stated, that low impact activities are tolerated or can be tolerated, so a low impact level walk may be tolerated by this patient, and it may be something that can be worked up to. The third question was about whether the patient would need to get up at night to eat to maintain blood glucose levels. The answer is that this is not necessary with being diagnosed with McArdle disease, and that glucose consumption can help for like a short burst of energy before the low impact exercise. But what has been recommended by physicians is continuing with a well-balanced diet that has carbohydrates and higher levels of protein in it. Some studies that have been done recently with patients that have McArdle disease have shown that patients that have a high protein diet are able to better tolerate some of these low impact exercises and increase slightly in their intensity due to this. The fourth question was about whether the patient needed to worry about producing excessive lactate during intense anaerobic exercise. The answer to this question is no. People with McArdle disease generally have very low levels of blood lactate after exercise, and they're not able to free glucose 1-phosphate from stored glycogen in the muscle, and this then impacts muscle metabolism under anaerobic conditions. So the next case that I chose to present on was case study number 4, which was on a 2-month-old female who's having jittery spells several hours after breastfeeding, and the labs were coming back showing that she was hypoglycemic. Epinephrine was administered, and there was no increase in blood glucose, but there was an increase in blood lactate. The physical exam also showed that the liver edge was 4 centimeters below the right costal margin, and percussion of the right chest and abdomen confirms hepatomegaly. Blood glucose levels increased after breastfeeding, but she was unable to maintain blood glucose levels within normal range during fasting periods. So there were 4 listed options for what the diagnosis would be, and I'm going to go through and explain my reasoning for why I think C is the correct answer and for how I ruled out the other 3 options. The first was hereditary fructose intolerance, which is defined by a deficiency in aldolase B. Some of the symptoms that patients can see are irritability after consuming fructose, and as we saw that the patient was experiencing these symptoms after breastfeeding, and lactose is a combination of glucose and galactose. So this didn't necessarily fit the bill because of this. And then but the hepatomegaly and the fasting hypoglycemia did fit, but the reaction to fructose was what ruled this out as an option. The second choice was galactosemia. I ruled this out pretty quickly just because galactosemia is one of the conditions that is screened for during newborn testing. So it would have been found out very early on after birth, and galactosemia in nature can be life-threatening and cause a crisis within the first few days after birth. And this would be highly unlikely as the patient is 2 months old at this point. The fourth option that I ruled out was glucose 6-phosphate dehydrogenase deficiency. Some of the main symptoms that I would have been looking for with that diagnosis would be fever, jaundice, anemia, and dark urine. Another thing that could be considered with diagnosing this patient was whether they were from African or Mediterranean descent, which can cause these populations have a higher rate of G6PD deficiencies. And the patient didn't fit that bill, as well as no anemia, fatigue, jaundice, or dark urine, which would have come up immediately within the physical exam and any other testing that we did. So the answer that I have come to was the glycogen disorder disease, specifically von Gurk disease. And some of the things that we would see with a patient diagnosed with this would be glycogen accumulation in the liver, renal tubule cells. They'd be hypoglycemic, lactic acidemia, ketosis, and hyperlipidemia. This diagnosis fits all of the symptoms that the patient is experiencing, and I think is the best answer for this case study.